The ED doctor or your resident is busy taking care of other patients, so she asked you to talk to the ED for her. Yeah, I got a 79-year-old guy coming in from home with a chief complaint of confusion, and he has a past medical. Oh crap! Trauma just rolled in. Can you take a look at his chart and I'll call you back? And you hang up the phone. And if you're like me, this is probably the face that you make. And this can evoke a lot of emotions. So really quick, to give our poll a chance, I want to think about when you see that ED patient coming up to your service and the chief complaint is altered mental status, confusion, acting off. What's the first thing that you're thinking about, or how are you feeling about that? Yeah, great job. Seeing a lot of things that I feel too when I see that, even as a third year resident and now a chief resident. I like the order everything. Definitely scared, worried about a patient, confused. Definitely things that I think we've all felt when we get that first call. So never fear, we're gonna hopefully be a little less scared, a little less worried as we go forward. So you pull up the ED triage note and you read that it says a 79-year-old guy, he's got hypertension and depression, coming in with 2 days of worsening confusion. You talked to, or the wife told the ED that he had trouble getting out of bed, put his shoes on the wrong feet, and then thought he was going to work, but he's been retired for years. He was able to make himself breakfast, but said that his food was filled with ants. So a lot of ways to describe what's going on with this patient. But does this patient have one of these: encephalopathy, delirium, encephalitis, psychosis, dementia, or do we need more info? Yeah, great. Awesome. All right, I'm gonna go ahead and lock that. You're gonna find that a lot of my, not too many of my trick questions are trick questions. I love the need more info, and I think that's 100% right. So let's go through when we're thinking about how to describe these patients, what we're talking about. I know everyone's eyes kind of glaze over, so these definitions will be really quick. So for encephalopathy is an umbrella term to describe anyone with altered mental status, any clinical state of altered mental status. This is not to be confused with encephalitis, which is true inflammation of the brain parenchyma, right? So we're thinking about mostly viral etiologies with encephalitis. I see a lot of notes that say encephalitis when they mean encephalopathy. So really easy to make yourself look smart by always putting encephalopathy. So when we think about encephalopathy, the other things I had asked you, does this patient have psychosis or delirium? Psychosis and delirium, we'll talk a little bit more about, but right, symptoms of encephalopathy can present in a million ways. So nurse may tell you that the patient's off. They may tell you that they're sleepy, they're forgetting things. They can present in a ton of ways. For specifically though, psychosis is a loss of contact with reality. So if we go back to our patient, he definitely had psychosis. He thought his cereal bowl was filled with ants. He thought he was going to work. So he could be described as having psychosis. And then delirium. Delirium is something that I'm sure you're all aware of. I'm sure you've all seen. If you haven't seen it, it probably means you're underdiagnosing it. But I want to talk a little bit more about delirium. So when we think about delirium, remember that this is a symptom. It's not the end diagnosis. It's a syndrome, relatively acute decline in cognitive function that fluctuates over hours and days. And an easy way to think about this is actually just go to the definition. So you actually need two of these features, and both 1 and 2, and either 3 or 4. It's not super important, but it helps me remember that anyone who has acute onset and fluctuating course of encephalopathy accompanied with inattention can have delirium. And ways that we test for this, right? So on the wards, or when you're seeing a patient in the morning, easy ways to test for this is serial 7s, and then clock drawing, spell the world backwards. That's a great way to test for inattention. And I guarantee if you walked around, I can see the Denver Health 9th floor right now. If you walked around the 9th floor and did this with every patient, you'd find that about 50% of hospitalized patients have some form of delirium. So there's delirium that we all kind of can recognize. So we get the really, crazy old guy just with a hyperactive form of delirium. Probably what goes more underdiagnosed is the really sleepy, impaired elderly woman. And I'm picking on old people. We know that the syndrome of delirium can happen to anybody. So when you're thinking about hyperactive versus hypoactive delirium, there's a couple really good clinical scenarios. So benzodiazepine intoxication can be a great example of what hypoactive delirium looks like, and then delirium tremens. So you have hallucinations, you have hyperactive or hyperarousal, and agitation. I wanted to point this out. So delirium, we talk about it all the time. Patients delirious in the ICU, they're delirious. And we don't realize a lot of times this is completely a non-benign syndrome that people have. A meta-analysis in 2010 actually showed that hospitalized patients with delirium are twice as likely to die. And when you think about dying, that's a pretty bad outcome. And they actually have 2-fold increased odds of being institutionalized and 12-fold increased odds of developing dementia. So when we talk about delirium on the wards, I want you to be cognizant that that is a serious illness and a serious syndrome that needs to be taken care of. All right, so we know what psychosis, we know what delirium are. So I think with this patient, you could definitely say he has encephalopathy. You could definitely say he has delirium. I don't think he has encephalitis, or we need more info like you all were saying. We need more info to say he has dementia, which is outside the scope of this talk. And then he definitely has psychosis. And like you all kind of acutely said, there's always need more info, and we're going to talk about that. Great. So we defined the different types of altered mental status. So next, we want to understand how are we going to think about this. So you're back to work, you're reading up on the ED, you start thinking about what could be causing this patient's encephalopathy characterized by delirium and psychosis, and you remember the differential for encephalopathy. So really quick, I want you to write down all the causes of altered mental status that you know. Yeah, great. So I can tell you are all fresh off of your sepsis lecture with Dr. Gergen yesterday. This is a great list to start. So infection, drugs, I see a lot of really good things. And honestly, if I had left this open, I'd bet that we could fill this entire sheet up, right? So these things, altered mental status can be basically caused by anything. And I think that's why some of those earlier things we were talking about, that sense of scared or overwhelmed feeling, I think that's where that comes from. So when we think about psychosis and delirium, I like to put things into big buckets. And 3 of those buckets are things going inside the brain, things going on outside the brain, and then things that we don't quite understand, or the psychiatric aspect of things that can cause altered mental status. And right, these can all lead to the symptoms of encephalopathy, psychosis, and delirium. So I want to touch really base. This is a little bit outside the scope of this talk, but for psychiatric things, so manic episodes, catatonia, you will see this, but it's rare. And I want to encourage you as you go forward in your internal medicine career that really treat those as a diagnosis of exclusion. I think a lot of people who come in have a history of schizophrenia, have a history of bipolar. Sometimes their altered mental status kind of gets chalked up just to their psychiatric complaint, and we can miss a lot of those underlying causes that you already mentioned. So intracranial, things going inside the brain and things going on outside the brain. This is why internal medicine docs get paid so much money, is because we can kind of work on deciphering these, right? So there's a ton of stuff under here that there's developing a good way to remember it. The way that I find best and I encourage you to move forward with is from the clinical problem solvers. This is the MIST mnemonic. I, for one, hate mnemonics, but I think this one's actually pretty good. One, because it's short and I can remember it. Another, because it has you can use a funny pun. You can't miss a diagnosis of altered mental status. So when we think about, I won't read through these, but we're going to go through some examples. So metabolic, things that are really common, electrolytes. I think some people mention this: renal failure, hepatic failure, hypercalcemia, infections, pneumonias, UTI, cellulitis. Think about things not just inside the brain. Everyone's really worried about missing a meningitis, but things outside the brain too. Structural, we talked about the intracranial. So these are really rare, and we'll talk a little bit more about that. But seizures, strokes, brain bleeds, and then dementia, I included in there as well. Again, that's a little bit outside the scope of this lecture, but. And then probably the most common thing we see that probably gets underdiagnosed is toxins. So ingestions, are they withdrawing from a toxin? And then probably more commonly, is this something that we gave them that's causing this? Great. So now we have at least a structure to start thinking through how we think about altered mental status using that MIST mnemonic, and then always keeping in the back of our mind some psychiatric causes. So now that we've done that, how are we going to approach it? I know someone in the beginning put order everything, right? That's not practical and probably not good medicine to do it. But how are we going to figure it out? So I'm going to refer back to this slide a lot. I like to think of how we should order meds and testing for altered mental status in kind of these tiers. So when you see a patient, everyone should get these things. They should all get a thorough history, especially as it relates to things that we're interested in. So medications, a good physical exam. So looking for things like asterixis, a focused exam for infections. And I say pan labs, and what I mean by that is if they haven't had a CBC, a CMP recently, then you should check that. And then glucose as well. Everyone should get these 4 things. And I'm going to show you and prove to you that with just those 4 things, we can already kind of tease out some things. So I want you to think about if you had to prioritize, what do you want when you're looking up this patient? You're going down to see them. What do you want first? Do you want vitals? Do you want a physical exam, more history, or labs? And you should be able to prioritize this on your phone. Yeah, great. So I think we're probably going to lock in there. And I agree. I think history is going to be the most important thing, followed by those vitals, a good physical exam. And then lastly, I usually take a look at the labs. So we're going to go to more history. And this is what you read. You look up his medical history. He's taking some blood pressure medications. He's not currently on any medication for BPH. And he recently started a TCA for his depression. And then you read his last PCP visit, which was a couple of days ago. He started that TCA, and then nothing else really pertinent there. You look at his labs. I'm going to not dwell on these. They look normal. And then you look at his physical exam. Really just confused, inattentive, and shaking. Neuroexam, non-focal, he's moving all extremities. Great. So right away with just those 4 things, I hope and I bet you're all thinking about a toxin induced. We'll talk about his TCA, but things that we always want you to think about are alcohol withdrawal. And alcohol withdrawal is not just in the 25-year-old who comes into Denver Health from Colfax. It's in the 76-year-old who lives in Cherry Creek and who has been drinking bourbon his entire life. So really always think about alcohol withdrawal, see if that could be causing this. Opioid overdose and withdrawal, I didn't include withdrawal, but definitely think about those 2 things. And then, like I said, more commonly, it's things that we're doing, so prescription meds. So in this case, this person's encephalopathy was likely secondary to starting amitriptyline. And I know a lot of you, as a future internal med, would know starting a 79-year-old on a TCA is not our first for depression. So good find. And remember, we did that with just these 4 things that everyone should get. Next, I do want to have a quick word on, I wouldn't be a future primary care doc if I didn't talk about giving elderly patients sedating medications. So benzodiazepine, opiates, anticholinergics, in this case a TCA, definitely want to be careful when using for someone who's over 65. All right, so we're going to run through this again. I'll skip this part. We'll just go through, I won't do the polling necessarily, but I'm going to show you that if you use these same things, you can, the same exact patient with a slightly different history, you can decipher what's going on. So in this case, this person has depression. They've been on sertraline for a year, doing well. You take a look at his labs, and in this case, he has a little bit of a white count to 15. He has a small AKI, and then you take a look at his vitals. He's febrile, he's desatting, and he's rhonchorous breath sounds, right? So I'm not trying to trick you guys. This would point you down a completely different route, so infection. Common things being common, any patient that you're working on for altered mental status, think about lungs, think about skin, lines and tubes, and then urine. So urine is one that's a little bit difficult, and you can have a whole lecture on talking about UTIs and altered mental status. We probably overtreat UTIs, but if someone's having urinary symptoms or you don't have another source, definitely think about it. But asymptomatic bacteriuria is not necessarily always the cause for altered mental status. And then lastly, the thing that we probably worry about a lot is the brain infection, so meningitis, encephalitis. Along those lines, I want to have a quick word on lumbar punctures. So someone really smart once told me that if you're spending time convincing yourself that you don't need to do a lumbar puncture, you likely need to do a lumbar puncture. I think it was Socrates, but I'm not entirely sure. No one fact checked me on that. And in all seriousness, though, there are really 2 examples when you need an urgent lumbar puncture. So one that we don't normally see is any suspected subarachnoid hemorrhage with a normal CT scan. Usually that's teased out in the emergency department. It doesn't end up on our floors, but it's something to remember. And then a suspected CNS infection. So if you are concerned about meningitis, really low threshold to go ahead and pull the trigger and do a lumbar puncture. Now, if someone has a rip-roaring pneumonia and it's obvious, you don't need to do that, but definitely keep it on your differential. And then I just always like to point out, there's no absolute contraindications to lumbar punctures. They are these 3 relatives, so thrombocytopenia, usually less than 50, possible raised intracranial pressure, and then if you're suspecting a spinal epidural abscess. And usually your imaging will kind of tease those things out for you. Great. So we know that these 4 things, doing these on every patient with altered mental status, can kind of help us narrow our differential. But obviously we can't stop there a lot of times. So based on what you find in that tier 1, expand your workup. So for this patient with the infection, we can expand our workup to do a chest x-ray, UA, blood cultures. If we're worried about his hypoxia, we can do an ABG. So I want you to remember that, yeah, based on the results of that tier 1, there's always that next step to going to tier 2. And then sometimes, right, we need to move even farther. and look into brain imaging. I mentioned the LP, autoimmune workups, broad and infectious workups, things like that. I really want to emphasize, always, always, always get a senior or an attending involved if a patient is unstable or if you don't have a clear diagnosis. Altered mental status, even if you're thinking this is just delirium, if you're not sure or there's anything pointing the direction that something else is going on, always smart to get someone else involved. Sam Porter put this together. It's a PDF that kind of goes through those tiers that I had talked to you about. I still have it on my phone. I use it all the time, especially on busy when you're admitting a patient or you're pre-rounding and you're like, this person's confused. This is going to take up so much of my time going through this and just being systematic about it. So I'll put this up again, but you get a chance to scan this QR code and save this to your phone. Great. All right, so we've gotten through most of this. I do want to touch base really fast on these can't miss causes of altered mental status. And when I say they're can't miss, I really mean because there are some instances when doing something, so treating, is more important than getting that definitive diagnosis. 3 things that come to mind for this are hypoglycemia, really important just to give D50 if you're even concerned about it. Glucose, even in patients that are really sick, if you have a DKA patient who's really sick, giving them D50 is not going to make them necessarily sicker, but if they're hypoglycemic, it could potentially save their life. Opiate overdose, naloxone, really low threshold to give that. We'll talk more about naloxone in a little bit. And then that last one is really just trying to remember your ABCs, right? So if someone is obtunded, someone is not protecting their airway, they need to be intubated instead of working on going through those tiers. Along with other treatments, I do want to touch base really quick on antipsychotics. So Haldol is probably the most studied. It's the one that I reach for the most, especially for those patients that are dangerously agitated overnight. This is where you can really flex your intern muscle. You will get calls all the time overnight of nurses saying, hey, this patient's agitated. We really don't want to be sedating patients unless they're in an imminent danger to themselves, another patient, or staff. If someone's just agitated and not sleeping, that's not a reason to give them Haldol. And then benzodiazepines. So these are for acute seizures. Do not give these to sundowning patients. Do not give these to patients to calm them down. You're going to be working up a whole new case of altered mental status if you do that. All right, so we're going to go through a few cases. We have about 20 minutes left, and we'll get right into it. So 69-year-old lady's coming in. She has hypertension, diabetes, heart failure, and is admitted for cellulitis. You come in the morning, and the nurse's patient calls to say the patient is confused. And she says, I had her yesterday, and she was not like this at all. So remember, everybody, and I'll go back to this, I'll emphasize this a few more times, everybody gets these things. So you go see her, you review her labs, and you go see her to do a physical exam. And here's what you find. So her vitals, I showed there. She's sitting well, but breathing slow. She is listless, unresponsive. She has no scleral icterus, and the rest of her exam is normal. I didn't put her whole neuro exam, but her whole neuro exam was normal. It's 6:18, so you don't have labs, but you take a look, and yesterday these were her labs. And then these are the medications she's on. I didn't add, she's also on ceftriaxone for her infection. So what's our next step here? Do we want to give her some oxygen, get a chest x-ray, give naloxone, check a ABG, or repeat vitals? All right, I'm gonna go ahead and lock that poll. Great. I think I like seeing a couple of things. So repeating vitals, I think that's always worth doing, especially as you're going to see, asking the nursing to repeat the vitals. I really like giving naloxone here, right? This is a patient that's listless and unresponsive and breathing at 8 a minute. She did have oxycodone on her med list. So with that said, how do we want to give naloxone? So she's sick enough. She's breathing 8 a minute. Let's give her 0.4 IV push, or let's give her 0.2 over a minute and see if she responds. All right, great job, everyone. Yeah, so this is a stylistic thing. I think a lot of the attendings and the seniors that you'll work with will really advocate for that second option. And why is that? So this person, now if you're between intubating someone and giving them naloxone, it's okay to give them an IV push. This patient is satting okay. Yes, her oxygen sats are fine. You have some time to give her the naloxone slowly. If you don't do that, a lot of our patients are post-procedural, so they're here after a surgery, they're here with fractures, all sorts of things going on. And if you give them an IV push and basically wipe out any analgesic effect of those meds, you're gonna have to wait for that naloxone to wear off before you're able to get their pain back under control. 99% of the time, you're gonna have time to give it slowly. You don't have to memorize this, but this is the technique that I use. So you can ask the nursing to take 1 ml of that solution, mix it, dilute it down in a 10 cc syringe, and then give it very slowly. And then you can always give more, right? You can give it over 1 to 2 minutes, and you'll see patients wake up. You'll see patients start breathing faster if it's working. So I would really encourage you, rarely would you want to give an IV push. Great, so you give that lady naloxone, she does great, and she gets discharged the next day. All right, so case number 2, we have a 57-year-old guy, history of CKD, status post-kidney transplants. He has some bad coronary artery disease, peripheral arterial disease. He's got a couple bilateral knee amputations, below knee amputations, and is getting treated for cryptococcal meningitis. You arrive at 6 for sign out. The night intern says that that patient was getting altered near the beginning of their shift, so they ordered some Seroquel and didn't hear anything the rest of the night. You prioritize this patient for pre-round and you see him first. Appears listless. He's responsive, but takes a few seconds. So remember, I'll harp on this again, everyone gets these things. So you review what you have. So these are his vitals. He is temperature is 37.8. He's a little hypertensive. He has a dialysis catheter in place. And he, so nothing else really on his vitals. You take a look, and these are the medications that he's taking. I'll have you all take a look, really highlighted by the heparin drip that he's on, the fluconazole he's getting for that cryptococcal meningitis. And then, And then these are his labs from this morning. He is scheduled to get dialysis today, and these are his labs. So start thinking about what's going on. You're in the room, you're with the patient. It's a little tougher, I think. So now we're in that first tier, right? We're still in that everyone gets these things. And I think this is a case when you need to move past this, right? So based on results of that first tier, you're gonna broaden your workup a little bit. So you need more info. I want you all to prioritize what tests you're going to want. And these are the tests that I'm given available to you. I don't know where those results went. Yeah. Great. Awesome. So I'm going to go ahead and lock it there. I like all these things. There's not a right answer here. I think it's just important to think about when you're thinking about your clinical reasoning on what's going to be most important. So yeah, so looking for, it looks like people are concerned about an infection. So they want to repeat these blood cultures, get a chest x-ray. I like that urine tox is down towards the bottom, right? So especially for a patient that's been in the hospital, urine tox, I don't talk too much more about this in this lecture, but urine toxes are pretty finicky. And for a patient in the hospital who's probably gotten a lot of different meds, whatever comes up positive on that isn't going to be super helpful. All right, so let me go past. All right, so I think first on our list, I will show the ABG first. You're all whizzes at ABGs thanks to Dr. Melton's lecture, so I won't dwell too much on this, but fairly normal, which is great. You get the UA, it shows some trace protein. You do the lumbar puncture as well. I like that that was also a little bit farther down the list. You think you have adequate treatment of the cryptococcal meningitis, so searching there again, especially immediately, is probably not going to be super helpful. And then those repeat blood cultures that everyone wanted. This was a case that I was actually part of. So this patient had actually been fevering and having low-grade temps for quite a while. And his blood cultures eventually came back positive for Klebsiella, and he had an infection, an undiagnosed infection. Great. So the last case that we're going to go through, this is now you're on cross cover at the VA. Your senior is busy with a really sick admission. And this is a 72-year-old guy admitted 9 days ago, been having fevers every day that they haven't been able to figure out. All his cultures are negative, and they're pretty sure he's not infected. And nursing calls and said he's less responsive right now. So again, I'm going to harp on this. Everyone gets the vitals, physical exam, and review of labs. So you take a look at his labs. Labs, fairly unremarkable. His meds are there. No recent changes to his medication. Then you look, he's febrile. We know he's been febrile. He is minimally responsive and diaphoretic. He has some increased tone, and but he's normal reflexic, and he's symmetric kind of all over. So remember, we need to go past our first tier because we're still not sure what's going on. So based on what the intern was worried about, did get an EKG, got some labs, repeated some blood cultures because they hadn't been repeated in a couple days, got a chest x-ray. Nothing super exciting. These are all normal. So right, we move into that third tier. And the nurse asks, she says, hey, should we order a CT of this person's head? So what are you going to tell her? What are your thoughts? Yeah, great. Great. So kind of a smattering. I want to ask, so either in the chat, people who put maybe, I want to know what you're thinking. Why are you thinking yes or no to the CT scan? I'll say again, there's not a right answer to this. Great. Yeah, great, Amelia, and the Denver Health ninth floor. So yeah, maybe helpful to check for bleed, increase intracranial pressure if you're considering doing an LP. Yeah, exactly. And I think for me, if I had seen this patient, I would have been in that maybe category too. I think things that we want to think about is, has this person had brain imaging? And then exactly, think of specific things that we're looking for. What we want to discourage is ordering CT scans for just altered mental status without a plan. So a quick word on head imaging. So strokes very infrequently cause altered mental status. And actually a normal neurological exam, which this person doesn't have, right? They are a little hypertonic, has a 97% negative predictive value for stroke in the setting of altered mental status. So really important to do and document a really good neuro exam, and then really be conscious. So like Amelia in the ninth floor at Denver Health were saying, be really conscious about what you're looking for with a CT or an MRI. Things to think about. So if you're ruling out structural causes, tumor, and then they had mentioned a brain bleed, so a subdural hematoma. Definitely things to when you would want to consider getting head imaging. All right. So this patient, like I said, gets everything. And last polling for the day, I do want to know what other tests. So we don't have a great diagnosis, right? You're back on the day team. You're talking to your team, and you want to order some more tests, trying to figure out what's going on with this guy. We have a guy who's persistently febrile, not no infectious source that could be found. He did get a CT and MRI that were normal. What other tests? Yeah, great. So I'm seeing a lot of things here. I like the encephalitis panel. That's one that gets ordered at the university, especially when you're 9 days in. I don't know if we can order it at Denver Health yet, but I like the LP. This person had actually had an LP that was normal. I like that. And then the EEG is actually kind of where we went with this case. And this person actually had non-clonic seizures going on kind of intermittently throughout his whole hospitalization. So something always to consider too, if you're a few days in or even early on, if you have some clinical suspicion, a spot EEG can be really helpful in these difficult to solve cases. All right, so for the last few minutes, just some really quick takeaways. So things that I want you to remember, don't stop at delirium. We talk about delirium all the time. It's not enough to just say this person's delirious. Why are they delirious? Do you have an infection that you haven't worked up? Do they have a new infection from being in the hospital? And remember, delirium kills people, right? So twice as likely to die if someone has delirium. So it's really important to understand and manage early on. Remember the Miss mnemonic? It's one of the few that I remember. It kind of helps me think whenever you have a patient who's altered and you're kind of banging your head against a wall because you want to order everything, anything can cause it. Remember the Miss mnemonic. Know the things that we want to treat quickly before working on our diagnosis. So treating seizures, treating hypoglycemia, treating impaired GCS with intubation if needed, and then giving naloxone for opioid overdoses. And then use that intern guide. That's helped me a bunch to kind of rethink and think of where I'm at in terms of my diagnostic algorithm. And I'll leave this up here just so if you weren't able to get it, scan it, save it to your phone. It's in a PDF file, so it can be really easily to just add onto onto one of your medical folders on your phone. And with that, I actually don't have anything else. We're done a little bit early, but I will be hanging out for a little bit. If you guys have any questions or any thoughts, feel free to either throw them in the chat. You can private message or throw them in the chat for everyone. Yeah, and congrats on almost being done with base camp. Just a few more days left.